Hello? Hello, are you guys able to hear me? Hello?
Yes, yes.
Okay, perfect. So as you guys know that today we are going to have like a bootcamp session on endocrinology in which we are going to be completing the entire system within 3 to 4 hours. So get yourself prepared for the embryology. We'll be starting from embryology and we'll be discussing the entire things which are going to be really important for you guys. So in order to make best out of this session, each and everyone should be having their first aid book in front of them, right? So I'll be marking the high yield stuff and the commonly tested questions by your NBMEs. And if you guys have any problem in the end, we are going to be having a question and answer session as well, right? So those who are having any doubt in the middle of lecture before opening their mic, they should just raise their hand in order to avoid disturbance, okay? So let me directly start our bootcamp session. So we'll be starting with embryology, right? So just give me a second. First of all, let me just share my screen, okay? Every one of you must be having their first aid book in front of them, right? So you guys can just annotate your first aid book if I'm just telling you some concept from NBMEs or UWord. So along with that, you should just write it down, right? Can you guys just see my screen?
Yes, sir.
Yes, sir.
Okay, perfect. Okay. So let's start with embryology. And the first topic which we are going to be discussing is thyroid development, right? So normally, how does the thyroid develop, right? That's a really important concept. Yes. Okay. Thyroid development. So you should just keep in mind that how does the thyroid develop, right? So basically, the thyroid developed initially as a thyroid diverticulum, right? So simply you can imagine that at the floor of your pharynx, or you can say at the base of your tongue, for example, if this is your tongue, first of all, you're going to be having development of a tissue or a diverticulum. Okay, what is diverticulum? Diverticulum simply is an outgrowth or outpouching, right? So thyroid initially is going to be forming in a form of a diverticulum, and this diverticulum is basically it must come to its original or original position, right, or original location. So what is the original location of your thyroid? It's basically anterior to your neck, right? Anterior to your neck. So initially it developed as a diverticulum from the primitive pharynx, and what happens then, it's going to descend down into the neck. But in order to descend down, it needs a pathway, right? It needs a specific pathway so that thyroid gland or the thyroid diverticulum can go there, right? So basically, you are going to be having a duct which is going to guide your primitive thyroid in order to come in its original location, that is anterior neck, right? So this duct is basically known as thyroglossal duct. Like this duct is going to be guiding this primitive thyroid to come to its original position, that is anterior neck, right? Normally, in each and every individual, this duct must be obliterated. Like after the thyroid comes to its original position, this duct should regress, right? But in some of the individual, this duct remain there, right? And what can happen as a consequence of them, there can be development of certain cysts within the ducts, right? It's a common pathology which can be associated with this entire embryology, right? So sometimes a cyst is going to develop in the persistent duct. If someone is having persistent thyroglossal duct, so sometimes there can be development of a cyst, right? And that condition is going to be called as thyroglossal duct cyst, right? So it's your thyroglossal duct. Whenever we have a persistent of thyroglossal duct, we're going to be having a cyst, which is known as thyroglossal duct cyst, right? Really important. So the first pathology which is associated with this embryology of your thyroid is thyroglossal. Kindly fix your mic. Each and everyone should please close their mic during the lecture in order to avoid disturbance, right? Thyroglossal duct cyst. So in your question stamp, you must be knowing what are going to be the presenting features of a thyroglossal duct cyst, right? It's going to be a commonly tested question on your UWord, on your NBME, right? So they're going to be telling you we have an individual. You come to clinic and the physician basically told an individual to either swallow his saliva, or he gave him a cup of water to drink that, or he tell the individual to protrude his tongue. After swallowing or protrusion of tongue, the physician basically see an anterior midline neck mass. So these two things, you should just keep these things in mind. Upon swallowing, and upon protrusion of your tongue, you're going to
Doctor, we cannot hear you.
Hello, can you guys hear me now? Hello.
Yeah, we do.
Okay. So I was discussing about thyroglossal duct cyst. So can you guys just tell me, do you got that, or I should just repeat that? Hello. Hello.
Yes,
Yes,
we got
sir, we
it.
got that.
Okay, so we were okay. Let me just give you a summary. Initially, we discussed that gland is going to be developing as a thyroid diverticulum at the base of your tongue, or you can say primitive pharynx. Then what happens? This thyroglossal diverticulum or thyroid diverticulum must go to its original position. So, what is the original position of thyroid? Everyone know that's anterior neck, right? How do it goes to its original location? Thyroglossal duct is going to help this thyroid diverticulum in order to get into its original location, thyroglossal duct. In normal individual, this thyroglossal duct must be obliterated. It must be regress. It should regress, right? But sometimes in some of individual, this thyroglossal duct remain the way and it do not regress. And in that cases, sometimes a cyst can develop in this thyroglossal duct. And that condition is going to be called as thyroglossal duct cyst. That's simple, right? So on presentation feature what would be the presenting feature of an individual having this condition, thyroglossal duct cyst, whenever a physician is telling him to either swallow his saliva or either drink a cup of water or either, just protrude their tongue. So the physician is going to see an anterior midline neck mass. That's going to be highly specific for this condition, thyroglossal duct cyst. You're going to be having a lot of MCQs on that. Is that clear? Hello?
Yes.
Perfect, right? So it was all about the embryology. Now we'll be moving towards endocrine anatomy, right? So anatomy is really important, right? And anatomy is like very less in endocrine, but it's really important. At least you must be having an idea that which hormones come from which location and which cells. That's really important, right? So we'll be starting from pituitary gland, right? We'll be starting from pituitary gland. Okay, all of us know that pituitary gland, it have like two parts, right? Your anterior pituitary and your posterior pituitary, right? So for example, if this is your pituitary stalk, your hypothalamus, so you are going to be having an anterior pituitary and, okay, let me just draw the posterior pituitary with different color and I'll be explaining why. Okay, so we have anterior pituitary and we have posterior pituitary gland. Okay, an important thing which you guys must keep in mind, the posterior pituitary and anterior pituitary, they are derivative of different things, right? Not same things. Okay, so anterior pituitary basically is derivative of your oral mucosa. What do I mean by that? Let me explain it, right? So during your developmental phases, for example, if this is an individual, okay, he's having like, it's his mouth, his nose. So from the oral or nasal mucosa, what happens? At the developmental stages, we are going to be having an outgrowth or outpouching, which is going to be arising from your oral mucosa. It's going to be detaching from this oral mucosa. It's going to be coming here like that. And this outpouching is going to join with your posterior pituitary. And this outpouching is basically going to contribute in formation of your anterior pituitary. Is that clear? How does the anterior pituitary gland develops? It develops from
Yes.
oral mucosa. How? During your developmental phases, the oral mucosa, from the oral mucosa, we are going to be having an out pouch or a pouch-like structure, a sac-like structure. It's going to be segregating from that mucosa. It's going to be traveling towards your posterior pituitary. It's going to be joining with your posterior pituitary. Once it joins with your posterior pituitary, it's going to grow. And once it's grown fully, we are going to call it as anterior pituitary gland. Is that clear?
Yes. It
Okay.
is.
So it's basically derivative of your oral mucosa, and it's very significant. Why? Okay, And posterior pituitary is basically derivative of your your neurons, or you can say some components of your nervous system, right? Some components of your nervous system. Okay, so you guys can see, as anterior pituitary is derivative of your oral mucosa, posterior pituitary is derivative from your central nervous system. It means the nature of both of these glands are going to be very different. You know what is oral mucosa? Okay, let me just tell you what's basically the name of this outpouching, which we'll discuss. What's the name of this pouch? We are going to name it as Radke's pouch.
Rathke's pouch.
Radke's pouch. Okay, so this Radke's pouch is basically going to join with your posterior pituitary, giving you your entire anterior pituitary gland, right? Radke's pouch. Okay, so here we have an important MCQs and important concept. Let me just tell you. Okay, you guys should be having, like, you guys are going to see this MCQ in your neurology section, in your endo section as well, right? One of your MCQ of your UWorld as well. So if we have a tumor of Radke's pouch, tumors of Radke pouch, it's going to be called as, what's the name of the tumor?
Craniopharyngioma.
Craniopharyngioma. Perfect. And this craniopharyngioma basically is going to be seen in less age, right? Children. Keep that in mind, right? Children. And what are going to be the presenting feature, like machine all? If you guys remember, there are different layers within the craniopharyngioma, the machine-like, oil-like appearance of some substances present within the tumor. It's going to come here and it's going to compress your optic chiasm. If the optic chiasm is compressed, we are going to be having bitemporal
hemianopia.
Hemianopia. Perfect. So these are going to be some presenting features. You are going to be having a child. The history would include child having like machine all like appearance within the tumor. The child is going to be having bitemporal hemianopia. So think of a condition which is cancer, or you can say tumor of your Radke's pouch, craniopharyngioma. Okay. So as we discussed that your anterior pituitary is derivative of your oral mucosa, it means that it's going to be secretory in nature, because oral mucosa is secretory in nature, right? Your mucosa secrete things, right? While if your posterior pituitary is derivative of your central nervous system, it won't be secretory in nature. It won't secrete anything, because it's the nature of neurons do not secrete anything, right? While the mucosa secrete things, right? So you should just keep that in mind. Anterior pituitary itself is going to secrete certain hormones by itself, while posterior pituitary do not have any ability to secrete hormone. While the hormones which are already formed within the hypothalamic nuclei, the magnocellular nuclei, remember? Yes. Just name those nuclei.
Paravertebral nuclei and supraoptic
Paraventricular and supraoptic. They are going to be making your ADH and oxytocin, and your posterior pituitary is only going to store these hormones. So it's going to be a store, like nature is going to be storage, right? While anterior pituitary itself is going to release a lot of hormones. Which hormones your anterior pituitary is going to release? Just keep that in mind, right? So FSH, LH, ACTH, TSH, prolactin, growth hormones, beta endorphins. Just keep that in mind, okay? So let me just write it down. FSH, we'll be discussing the entire details of FSH, LH, and everything, right? Your LH, ACTH, along with that, your thyroid stimulating hormone, your prolactin, along with that, your growth hormone, beta endorphins. Just keep that in mind, okay? Melanin as well, right? So, okay, just remember, like your anterior hormone do not directly release these hormones. You need some of the releasing factors coming from your hypothalamus, right? So the hypothalamus is going to release some releasing hormones. It's going to be acting on your anterior pituitary, and anterior pituitary then is going to release these hormones. Keep that in mind, right? So like for example, growth hormone, releasing hormone, right? It's going to be coming from hypothalamus, right? Then it's going to be acting on your anterior pituitary, giving the release of growth hormone. Is that clear? Is that clear?
Yes.
Okay. So another thing which you should just keep in mind is that okay, so we discussed the concept of like the stimulating hormone coming from your, or the releasing hormone coming from your hypothalamus, right? Then we have our posterior pituitary. We discussed its derivative of your neural ectoderm. It means it won't be any secretory in nature. It's only going to store the hormones which are coming from your hypothalamus, that is ADH and oxytocin, right? So here you have your ADH plus oxytocin storage, which we'll be discussing in detail, right? So the next topic or the next anatomy which we are going to be discussing is adrenal cortex and adrenal medulla, right? So everyone know that, for example, if this is your kidney, so on the surface of your kidney, you have a gland which is known as adrenal gland, right? Adrenal gland itself have two zones, the outer cortex and the inner medulla, right? Hello?
Yes.
Okay.
Yes,
The
sir.
cortex itself is going to be divided into three layers. Keep that in mind, right? And the mnemonic for that is G, F, and R, right? Zona glomerulosa, zona fasciculata, and then zona reticularis. And each of these zones are going to be releasing different hormones. Like glomerulosa would release your aldosterone once it gets stimulus, and the stimulus for the release of aldosterone are two: increase angiotensin 2 and increase K plus, increase potassium and increase angiotensin 2. Keep that in mind. Okay, so there are two stimuli, that is increase potassium plus increase angiotensin to keep that in mind. Okay, the fasciculata itself is going to release a hormone which is cortisol. Really important. We are going to be discussing the entire details of cortisol, and reticularis is going to release androgens. All of you know what are androgens, right? Okay, so we'll be discussing the entire physiology, the entire pathology related with each and every hormone. But keep one thing in mind: if you guys know the physiology of endocrine, pathology is going to be a piece of cake for you guys. Okay, so in pathology section, I'll be asking you guys that what would happen. So I'll be spending some time on physiology, and you guys are going to be contributing more in your pathology section. So that's all for now regarding the anatomical aspect of your adrenal cortex. Then we are going to be having another gland, that is pancreas, right? So pancreas itself is having some endocrine functions as well, right? Exocrine plus endocrine, right? So the endocrine functions are going to be releasing certain hormones that are your insulin plus, yes, glucagon, right? Hello? Hello?
Yes. Yeah.
Okay. And along with that, what about somatostatin?
Somatostatin.
Okay, perfect. So insulin is going to be released from which cells? Your beta cells of your islet of Langerhans, right? And your glucagon by your alpha cells,
Cells.
and somatostatin released from your, yes, which cells? What is this called?
Delta
Delta
cells.
That's
cells.
delta cells. Perfect, right? So this was all about the anatomy. Now we'll be moving towards endocrine, right? So endocrine physiology, sorry. So in the endocrine physiology, we'll be discussing different functions of these hormones. As I already mentioned, physiology is really important, right? If you guys know the physiology, pathology is going to be really easy for you guys. Okay, keep that in mind. So we'll be starting with the first hormone, that is ADH. As you guys can see, those who do not know what is the function of ADH, the name tell you everything. What is ADH? Anti-diuretic hormone. What is
Antidiuretic hormone.
Yes, it's anti-diuretic hormone. What is diuresis? Diuresis mean, like, producing urine, right? Or urination or diuresis. These are same things. Anti-diuretic. If this hormone is released, it won't let you to urinate. It would stop diuresis, right? So it means that it's going to reabsorb all of the water content, right? Because most of your urine is water, right? Can I say that?
Yes.
Hello? So can I say that antidiuretic, the function of ADH is to, yes, increase water reabsorption. Increase water reabsorption. And as we already discussed, ADH is going to be released from your posterior pituitary, right? Not released, it's stored there. Originally, it's made within the magnocellular cells, right? Within the hypothalamus, right? Okay, so what would be the stimuli for the release of ADH? Okay, can anyone just tell me what is the normal osmolarity level present in your body? What's the normal osmolarity? Can you guys just tell me the average number for that? 290, right?
275
290
to
milliliters.
Almost 290,
290.
right? Whenever the osmolarity increases, what do we mean by increase osmolarity? As the name indicates, increase osmoles. Whenever the solutes increases, whenever the osmol increases, so the osmolarity is going to go up, and it isn't good for your body, right? Like for example, within the extracellular fluid, if the osmolarity increases, how do osmolarity increases within the extracellular fluid? You can just think. Either if an individual is having, if he is dehydrating, I'm just removing all of the water content, it means now we are only left with osmoles. So now we are increasing the osmolarity. What would be the outcome of that? If we are increasing the osmolarity within the extracellular fluid, it would drain all of the fluid from the intracellular fluid, right? And the cells can undergo, you can say, dehydration, right? So whenever the osmolarity increases, the release of ADH is going to be triggered, right? So the trigger for the release of ADH is increased osmolarity. Whenever any condition which increases osmolarity, which increases the osmoles in your body, you need water to neutralize them, right? You need extra water to neutralize that. So for that purpose, your ADH is going to be released. It's going to come, it's going to act on your collecting duct. It's going to act on your collecting duct, and as a result, on a distal convoluted tubule as well. So acting on those two places within your kidney, we are going to be discussing that in detail. It's going to suck water from your urine, right? And in this way, the osmolarity is going to be like you are diluting the concentration, or you are diluting that concentrated amount of your osmoles, right? Keep that in mind. So remember, there are two receptors, V1 receptors and V2 receptors, right? So the idea is really clear. For example, if this is the, let's suppose, you are collecting duct, right, in the medulla. So we know that medulla already is really, has really high osmolarity. There are a lot of osmoles present with the medulla of your kidney, right? So what your ADH is going to do, it's going to install V2 receptor here and aquaporin receptors, right? So once the aquaporin receptors are opened, so as the osmolarity in the medulla is already high, it would just drag all of the water passively from your urine, and in this way, this water is going to enter into your blood vessels, and the increase in osmolarity is going to be corrected in this way, right? So this is the mechanism. Okay, ADH. Okay, ADH is also known as another. What's the other name of ADH?
Vasopressin.
I can't hear you guys. Please, one by one, just say it.
Vasopressin.
Vasopressin. Perfect. Vasopressin. So as the name indicates, vasopressin, it's pressing your vessels, right? Pressing your vessels. Vasopressin. It means, can I say that it's going to press your vessel? Whenever we are pressing or constricting our vessel, it means we are inducing hypertension, right? We are increasing the pressure. Can I say that?
Yes.
Okay. So whenever the ADH act on V1 receptor is going to be acting as vasopressin. But we have a pathology as well. If you guys remember, von Willebrand factor disease, and one of the treatment option for von Willebrand factor disease was giving ADH, giving desmopressin, right? Did you guys remember?
Yes, sir.
Yes.
Yes.
So the idea was that your von Willebrand factors are basically formed within the bodies within the endothelium, which are known as Weber palate bodies in association with your factor 8. So it's also going to trigger the release of von Willebrand factors from your Weber palate bodies, right? Which we are going to be discussing in detail in our hematology sections. Is that clear? Hello?
Yes, sir. Okay.
Perfect. So let's move to our next hormone. Okay, that is CRH, right? CRH. As the name indicates, it's okay. What do we mean by what does CRH stand for? Corticotropic releasing hormone. Right?
Cortisol releasing hormone.
It's a corticotropic or a cortisol releasing hormone.
Cortisol releasing hormone.
Okay, you can say both. No problem. Okay, you can say both. Okay, but the main idea, it's a releasing hormone, and I just told you guys, whenever we have a releasing hormone, it would be coming from hypothalamus.
Hypothalamus.
So releasing hormone comes from hypothalamus, right? And for example, if this is your hypothalamus, CRH is going to be coming from your hypothalamus. It's going to be acting on your anterior pituitary, and it's going to be triggering the release of ACTH. That is adrenocorticotropic hormone, right? We are going to be discussing that. But remember, can you just please fix your mic? Okay. But remember, the ACTH basically is formed from a precursor molecule, and that precursor molecule is known as POMC. That is pro-opiomelanocortin, right? Okay. So the precursor molecule for the formation of ACTH is POMC. It's really high yield, really significant. I'll be telling you the significance of this POMC in a pathology that is 21 alpha hydroxylase deficiency or congenital adrenal hyperplasia, right? There we are going to be seeing something, right, which is basically the outcome of POMC, right? So as the name indicates, right, so we are going to be breaking out the name pro, opio, melanocortin. So you guys can see POMC is made up of especially like three things, right? The melano stands for melanin. It means it's a precursor molecule for the formation of melanin as well. Are you guys getting me? Opioids. Opioids are basically, your analgesics, right? In the body, you have a specific, system for analgesia, right? So in that, you are going to be having release of certain endorphins, which mimics your opioids, right? So the beta endorphins, which are like, component of your analgesic system. We'll be discussing analgesic system in detail in our CNS, which includes the periventricular nuclei, your nuclei of Refi. It's going to release beta endorphin, serotonin, which is going to decrease the level of stress, or it's going to give you an effect of analgesia, right? We'll be discussing that in our CNS model. So what beta endorphins are going to do? Okay, so it's going to be a precursor molecule not only for ACTH. It's going to be a precursor molecule for your melanin pigment. It's going to be a precursor molecule for your opioids as well. Right? Pro-opio melanocortin. You should just keep this name in your mind, and everything is going to be clear for you, right? So we'll be discussing the significance of POMC. Just keep that in mind. Okay. Okay. So as the ACTH is released, so what do ACTH stand for? That is adrenocorticotropic hormone. Adrenocortico. It means, okay, like it's very simple if you just break down the names, right? Everything just feels very simple. That is adrenocorticotropic hormone. It means that it's going to enter the cortical area of your adrenal gland. Adrenocortico. Tropic. What do we mean by tropic? Tropic means turn on, right? Whenever we are saying that this hormone has an tropic effect. Tropic effect means a turn on effect. It's going to turn on, right? It's going to stimulate the release. So adrenocorticotropic hormone, it means it's a hormone which is going to enter the cortical area of your adrenal gland, and is going to turn on the function of certain hormones. And what's going to be those hormones? As we discussed, we have G, we have F, we have R. So adrenocorticotropic hormone, basically it would stimulate your F area, it would stimulate your R area. And from the F, we have formation of cortisol, right? Remember? Hello? And
Yes.
from the R area, we have androgen, right? So, and remember, the cortisol basically is having a negative feedback mechanism or a system on ACTH, right? So whenever the release of cortisol is increased much more than a significant value, than a proper appropriate value, it's going to inhibit the release of ACTH, and in this way, this pathway is going to be controlled. That's simple, right? So let's move to our next hormone, that is your prolactin, right? Prolactin. So as we discussed, prolactin comes from your anterior pituitary again, right? So for example, if this is your pituitary stalk, your anterior pituitary, your posterior pituitary. So what you have like lectrotrophs, which are going to make prolactin, right? Okay. So remember, as we discussed that we are going to be having releasing hormones, which normally controls the release of different hormones into your anterior pituitary. But in case of prolactin, the dopamine, so you have a nucleus which is known as arcuate nucleus, right? So the dopamine basically in the arcuate nucleus, it's going to be having an inhibitory effect on your prolactin. What do I mean by that? As the dopamine increases, the prolactin would decrease, right? So it's having an inhibitory effect on prolactin. As the dopamine increases, it would inhibit the release of prolactin. Whenever the dopamine decreases, the prolactin is going to be very high. And what's the function of prolactin? Yes, can anyone just tell me, please? Just be quick.
Milk production and development.
Okay, it's going to stimulate lactogenesis, right? That is milk production. But it's also going to inhibit your GnRH, right? What is GN? Gonadotrop. Okay, what is GnRH?
Gonadotropin release.
Gonadotropes.
releasing hormone. So if the GnRH decreases, it means the FSH and LH would decrease, right?
Yes.
So if an individual is having a tumor and which is releasing a lot of prolactin, so won't you think that let's suppose if she's lady, she'll also be having complaint of amenorrhea, right? Because for the release of for the normal, for the normal cycle or menstrual cycle, you need FSH and LH, right, which we'll be discussing in detail in our reproductive session, right? So the prolactin further is going to inhibit your GnRH. Once GnRH is inhibited, FSH, LH go down. If that don't go down, it would just present like as amenorrhea in female, right? And in male, it would just present as decreased libido, right? Because for the production of testosterone, right? What do we need for the production of testosterone? LH is going to go into your testicular cells, and it's going to the Leydig cell, right? And it's going to make your testosterone. Everyone knows it, right? So if you have less LH, less testosterone, testosterone further helps in libido, so there will be decreased libido if you have prolactinoma. Is that clear? These kind of MCQs are going to be appearing in your exam. Keep that in mind. Really important. Okay. Hello.
Yes.
Yes.
Okay.
Yeah.
So let me just tell you a classic MCQ of your U word, right? For example, if we cut the pituitary stalk, if we are cutting the pituitary stalk, right? We are cutting the entire pituitary stalk. The level of all of the hormones are going to be going down, except one hormone, which is going to be moving, like increasing. What's that?
Prolactin.
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 And why? Because we are basically, decreasing the negative or the dopamine, increased dopamine, which is inhibiting your prolactin. So if you are releasing that factor, we are releasing the dopamine. So now your electrotrophs are free to produce a lot amount of prolactin. A problem which decrease GnRH, decrease FSH, LS, and everything, right? So this was all about your prolactin and dopamine, right? So dopamine is really important, not only here, right? So in your nigrostriatal pathway, which we'll be discussing in our CNS section, if you have, dopamine normally comes from a structure substance in nigra. It helps your basal ganglia in a form of nigrostriatal pathway. We'll be discussing that. If we have the dopaminergic neurons are lost, we are going to be having a condition Parkinson's disease. Everyone knows that, right? So dopamine is really important, right? So for example, if you have an individual, he or she is having a tumor, prolactin tumor. So what do you think? What can be the treatment approaches for that?
Dopamine agonist.
Dopamine agonist. Okay, what are your dopamine agonists? Can anyone just name one or two?
Bromocriptine and
Gabapentin and
gabapentin.
bromocriptine. Perfect, right? Okay, so we already discussed the function of GnRH. GnRH is basically a releasing hormone. It means it would be coming from your hypothalamus, acting on your anterior pituitary, increasing the release of FSH, LH, and in this way, it's going to help your menstruation, or it's going to help your, like in male, it's going to increase the level of testosterone, making sperms. It's going to help that, right? So really important. MSH, melanocyte stimulating hormone, right? So basically, it's going to increase the melanogenesis. What is melanogenesis? It's the production of melanin, black color pigment, right? So cause of hypertension in Cushing disease. So what is Cushing disease? Keep that in mind, okay? I'll be just telling you the significance of, as I just discussed, POMC, right? Okay. So Cushing disease is a disease in which we have increased level of cortisol, right? So it can be primary or it can be secondary, right? We'll be discussing that. So the primary mean whenever, for example, if you have a tumor in the zona fasciculata, it's releasing a lot of cortisol. So that's going to be a primary Cushing disease. And a secondary, okay, that's also known as Cushing syndrome, right? And the secondary, for example, if you have a tumor, it's releasing a lot of ACTH. So ACTH further is going to trigger the release of cortisol, and again we'll be having hypercortisolism, right? So there is a primary cause and a secondary cause, and the secondary is basically known as Cushing disease, the primary is known as Cushing syndrome, right? So if in case of secondary Cushing disease, it means we are going to be making a lot of ACTH, which is going to be causing increase or hypercortisolism, right? But ACTH comes from a precursor molecule POMC. It means that we'll be having a lot of POMC. But POMC do not only make your ACTH, but it also make your melanin as well, right? So in secondary hypercortisolism, we'll be having hyperpigmentation. That is increased due to increased activity of the melanin component of your POMC. Is that clear? Hello?
Yes, sir. Clear.
Yes, sir.
So the next thing or the next hormone is oxytocin, right? So what is oxytocin? As we already discussed, it's made in your cells of your hypothalamus, and further is going to be, be stored in your posterior pituitary. What's the function of that? Everyone know that uterine contraction during labor requires oxytocin, the milk letdown effect, to as a response of suckling, right? All of us know that. It also modulates like fear, anxiety, social bonding with the baby, mood, and depression. Simple, right? Just keep that in mind. Okay, we have somatostatin. What is somatostatin? Just keep one thing in mind. Somatostatin decreases a lot of hormone, right? Somatostatin, right? Statin. It would just stop a lot of hormones. For example, the growth hormones and TSH, right? So somatostatin is an inhibitory hormone, right? It's not only present like there in the pituitary, but it's also present within the islet of Langerhans, as we discussed the delta cells, right? That's important. Okay, for the release of TSH, thyroid stimulating hormone, we need TRH, thyroid releasing hormone, right? But thyroid releasing hormone do not only increases the release of TSH from your anterior pituitary, but it also releases the increase of prolactin, which is really important, right? Let me tell you the significance of that. For example, again, if you have hyperthyroidism, so hyperthyroidism again can be of two causes, primary or secondary, right? What do we mean by primary hyperthyroidism? If your thyroid gland is having, let's suppose, a tumor, or it's releasing that tumor is releasing a lot of T3 and T4, that would be a primary cause of hyperthyroidism, right? And in turn, this T3 and T4 is going to be inhibiting your TSH and TRH both. But if the cause of hyperthyroidism is a secondary cause, what do I mean by secondary cause? If it's due to increased TRH release, increased TSH release, if we have tumor up there in the brain, right? So we'll be having hyperthyroidism again. But in that hyperthyroidism, we'll be having increased level of TSH or TRH in contrast to the primary hyperthyroidism. Is that clear? Hello?
Yeah.
The secondary.
So, for example, if it's a secondary cause of hyperthyroidism, if it's due to increased TRH, increased TSH, right? So it means that we are also going to be having prolactinoma, or we'll be having no prolactinoma, by the way. We'll be having increased level of prolactin as well, because TRH also increases the release of prolactin. Is that clear?
Yes.
Okay. So this was all about the hormones which we discussed. So let's have 5 minutes of break, and then we'll be continuing our lecture. We'll be discussing the next hormone, right? So you have to be, mentally prepared for today's boot camp. Those who do not know, we're having a boot camp in the end of every system. So it will just take a lot of time, okay? And after that, we'll be having an assessment session. Thank you so much. Let's have a 5 minutes of break, and then we'll be returning towards the lecture. Thank you so much.
Doctor, we cannot hear you again.
Hello. Actually, it was a break, and now we'll continue our section. The break is over. Okay. Hello.
Okay.
So, just give me a second. Okay. So now we'll be discussing each and every hormone along with some of the pathologies associated with every hormone, and we'll be just discussing in depth, right? So we'll be starting from our first hormone, that is growth hormone, right? Growth hormone. Okay. So as we know, as the name indicates, growth hormone, it means that growth hormone, it's going to help us grow a lot of things, right? Your muscles, your bones, but keep that in mind. Growth hormones do not, like it do not just do its activity by its own. There is an intermediate present which basically performs the activity of growth hormone. That is basically released by your growth hormone, right? I think you guys will be confused about my statement, but let me just clarify each and everything, right? Growth hormone, as we already discussed, it comes from your anterior pituitary, right? But for the release of growth hormone, we need a stimuli, we need a releasing hormone. And we know releasing hormone is going to be coming from your hypothalamus, right? So growth hormone, releasing hormone coming from your hypothalamus is going to trigger the release of your growth hormone, right? And growth hormone in turn is going to be released in your blood. And the growth hormone is going to, it's as I mentioned, it's not going to directly perform its activity. In the liver, it's going to be converting into another intermediate, that is IGF-1, insulin-like growth factor 1. And that insulin-like growth factor 1 is going to be the potent form of your growth hormone, which is going to be performing the activity of growth hormone, right? And what are the function of growth hormone? It's going to help, yes, what's it going to do? It's going to help grow your muscles. It's going to increase your protein synthesis, increase DNA synthesis, increase collagen synthesis, increase cell size number, increase amino acid uptake, right? So it's going to help us synthesize a lot of things, right? And you guys can just keep in mind, if your IGF is helping your muscles to grow, right? So for the growth of muscles, we require energy as well, right? And we know that the major source of energy in our body is basically glucose, right? So simply you can just imagine it in a way. If the growth hormone increases the growth of different tissues, of the different muscles, right? So for the growth, we need glucose as well. So it means that growth hormone is also going to be increasing the level of glucose, right? So if growth hormone is increasing the level of glucose, causing hyperglycemia. So can I say that growth hormone is diabetogenic in nature?
Yes.
Yes. So growth hormone is
Yes.
diabetogenic in nature, right? It's going to increase the level of glucose, but the glucose in turn have negative inhibitory mechanism of on your growth hormones as well as your growth hormone releasing hormone, right? And that's very important, right? That's very significant. Like whenever the growth hormone is released, it's going to increase your glucose within the blood, and glucose in turn is going to negatively inhibit the release of growth hormone or your growth hormone releasing hormone, right? It's very important. Okay, why is it important? For example, if we have an individual and you are suspecting that he have a tumor which is releasing a lot of growth hormone, that is if he is child, it would be, this condition would be known as gigantism. If it's an adult, it would be in a form of acromegaly, right? So the first thing which you are going to do is to check whether this axis is working or not. So you are going to give him a glucose, oral glucose, and once he drinks the oral glucose, solution. So the glucose normally should inhibit your growth hormone or growth hormone releasing hormone, right? But in those individuals who have any kind of tumor, it won't be inhibited. And in this way, you can somehow diagnose that this individual must be having a tumor releasing a lot of growth hormones. Is that right? Hello?
Yes.
Okay, perfect.
Yeah.
So the next thing, when does the growth hormone production increases? During which phases, right? So whenever an individual is sleeping, it increases the growth hormone. You know, the babies always sleep, right? for 15 hours, 16 hours, basically it's going to, then it triggers the release of growth hormone, right? So sleep is really important for the release of growth hormone, except that hypoglycemia. If you have hypoglycemia, you are having less inhibition on growth hormone release, so in that way, growth hormone is going to be released more, right? Similarly, if we have, during exercise, growth hormone also release, right? Increase. So as we mentioned, whenever we have excess growth hormone in children, those condition is going to be known as gigantism. If it's in adult, it's going to be acromegaly, right? We will be discussing both gigantism and acromegaly in detail in our further slides, okay? So what's going to be one of the treatment option of a tumor releasing a lot of growth hormone? It's going to be like giving somatostatin, because we discussed somatostatin inhibits your growth hormone, right? So one of the analog of somatostatin is octreotide, right? And we can also undergo a sphenoidal resection of that tumor. That's really important, right? So we can just do these two things, which can help an individual with tumor releasing a lot of growth hormones. Okay, so another thing. In case of growth hormone, as we mentioned, that is going to increase the growth of a lot of structures, even in the heart. So in the heart, it's going to cause hypertrophy, right? So for example, it's one of your classical world question. We have an individual. Let's suppose he's 24 years of age. He's having a lot of thick bones, thick jaw, frontal bossing. In the heart, we are going to see hypertrophy as well, right? Keep that in mind. It's going to increase the heart, is going to increase the hypertrophy process in the heart. Keep that in mind. Okay, you have a word answer. So the next hormone which we are going to be discussing is ADH, right? So we already discussed ADH in detail, right? We discussed it's going to we know each and everything, right? But for the ADH, there is a pathology that is known as diabetes insipidus. We'll be discussing that in detail in our pathology section. So for now, just skip it, right? So you guys can just read. We discussed each and everything about ADH already. Right? Okay. The next is prolactin. We also discussed prolactin. Let me just give you a brief overview again. It increases the milk production. It inhibits GnRH, which in turn inhibits your FSH, LH. You know that, right? It's released by your anterior. Dopamine have a negative, it would just inhibit the release of your prolactin. So for example, if you have prolactinoma, give dopamine agonist and everything. We already discussed it, right? So let's skip this topic as well. Okay. So next topic is thyroid hormone. It's really important. So we are going to be spending some time on thyroid hormones, right? Okay. Thyroid hormone. So we'll be starting from the top, right? From the hypothalamus. As we know, we have hypothalamus, we have pituitary stalk, we have our anterior pituitary, and we have our posterior pituitary, right? So from the hypothyroid, we are going to be having the release of a releasing hormone, that is TRH, thyroid releasing hormone. This thyroid releasing hormone is going to be acting on thyroid troughs, which are going to be releasing TSH, thyroid stimulating hormone, right? Once thyroid stimulating hormone is released, it's going to be acting on your thyroid gland. We have a thyroid gland receptor, right? And once it stimulates the thyroid receptor, so we are going to be having three processes there, right? That is a single enzyme, thyroid peroxidase, is going to be activated. And what thyroid peroxidase is going to do, it's going to undergo three processes. Yes, please going to be telling me that.
Oxidation or gamification of iodine and coupling of the monoiodotyrosine.
Perfect. So what would happen? Let me just clarify it. Okay. So as this TSH act on the TSH receptor, we are going to be having more iodine intake into the thyroid, right? Thyroid gland. And that iodine further is going to be added, like we have a big molecule which is known as thyroglobulin. And on the surface of thyroglobulin, basically we are having tyrosines, a lot of tyrosines, right? So what happens whenever we have iodine is entered into the thyroid, and the thyroid is going to be entered into the thyroid lumen, and there this iodine is going to be combined, it's going to be added onto this tyrosine molecules, right? And addition of this iodine onto this tyrosine molecules, which come from a big thyroglobulin, is known as organification, right? We are organifying iodine. Then what happens? Some of the tyrosine would receive 2 iodine, some of them would receive 1 iodine, right? So for example, if this is a tyrosine molecule, some of it would be having 2 iodine, some of it will be having one iodine, right? Some of it will be having two iodine, some of it will be having one iodine. So whenever the two and the two iodine combine with one another, there will be resulting in formation of T4. That is tetraiodothyronine. So as the name indicates, what is T4 tetraiodo? 4 iodines present. And whenever we have combination of your two iodine with a single, it would result in formation of T3. That is triiodothyronine, right? So this is the entire, physiology. You can say how do the thyroid hormone normally is like in a form. Okay, so once this T4 is released into the blood, so abundance of the hormone which is coming from your thyroid is going to be T4, right? But T3 is more potent, right? So the effect of T3 is very high. Like the potent form is T3, but the abundant form is T4. It means that T4 peripherally is going to be converted into T3. How do we convert T4 into T3? That's simple. Just remove one iodine, right? From the 5' location. So the enzyme is 5' deiodinase. So if we just remove one iodine from the fifth prime carbon location, it's going to be converted into T3, which is going to be more potent form of your thyroid hormone. It's going to be, giving you a lot of actions of thyroid hormone. That's really important, right? And we have a single enzyme which undergo all of these three processes. That is thyroid peroxidase helps in all of these three processes: oxidation, organification, and coupling. Is that clear? Hello?
Yes.
So, for example, if you have an individual, he's having hyperthyroidism, so we are going to be having certain drugs which is going to block your thyroid peroxidase, right? Like, for example, PTU, it blocks thyroid peroxidase, propylthiourate. So, in this way, we can stop the formation of excessive thyroid hormone and we can help this individual because we know that this single enzyme is going to be, responsible for the formation of these entire molecules, T3 and T4. That's simple, okay? Okay. So we have an effect which is known as Wolff-Chaikov's effect. What is Wolff-Chaikov's effect? It's really important, right? So as we discussed, iodine intake is really important for the formation of your thyroid hormone. So Wolff-Chaikov's effect states whenever we have a lot of iodine, right? So what happens? A lot of iodine if are traveling or into your thyroid gland, it would temporarily shut the activity of your thyroid peroxidase. So what does the Wolff-Chaikov's effect state? That abundance of iodine would, it would halt or it would stop the activity of your thyroid peroxidase, but it would be a temporary stoppage of your thyroid peroxidase activity. So in other words, I can say if you are giving a lot of iodine, it means we will be decreasing the formation of your T3 and T4. That's simple. Okay. And as I mentioned okay, so there are a lot of drugs which also inhibit this enzyme as well. So for example, if you have an individual and what we are doing, we are basically, he's having hyperthyroidism. So we can also use certain drugs which decreases the activity of this hormone, right? And as the activity of this hormone decreases, it's going to help an individual. Why? Because now the T4 won't be converted into T3, which is more potent form, more effective form. So in this way, you can just help an individual with hyperthyroidism. And one of the drug is beta blockers, right? Beta blockers. So you're going to be having an MCQ in UWorld, right? Okay, let's discuss that in hyperthyroidism not now, okay? Now the T3 is released. So the question arises, what's the function of T3? So the function of T3, you can just simply remember two things. And everything is going to be so simple for you guys. It would increase the basal metabolic rate. And what else would it would do? It would increase your sympathetic drive. Okay, so it's going to be doing two things: increase basal metabolic rate and increasing your sympathetic drive, right? So how does it increases your basal metabolic rate? That's really important, right? So normally on every cells, we know we have a pump, that is NAK plus pump. Everyone knows it, right? That's very simple, right? Like in order to make depolarization, you need a negative charge, like below the membrane, and that's also done by your NAK plus pump, right? Making your cells negative in order to carry out depolarization and normal function, right? So what T3 and T4 is going to do, it's going to increase the activity of your NAK plus pump. If I'm increasing the activity of NAK plus pump, what do you think? Will increase will increase thyroid hormone or thyrotoxicosis causes hypokalemia or hyperkalemia? Very important. Yes. Hello? In case of thyrotoxicosis, we'll be having hypokalemia or hyperkalemia.
Hypokalemia.
Yes. What do you guys think? Hypo or hyper?
Hyper. As the sodium go.
Hypo.
Hyposodium will go to the outside.
Hypokalemia, right? So what happens? Sodium is going to, if you are increasing the activity, normally the sodium move out, right? Free sodium move out to NA comes, right? So in this way, you are going to be having a negative, right? So we are going to be having hypokalemia. Okay, perfect. And along with that, we are going to be having increased sympathetic drive, right? So if you're increasing the activity of this pump, it's a pump. It means pump requires ATP, right? ATP consumption. Hello?
Yes.
Yes.
And from where do the ATP come? ATP basically come from the glucose, right? Okay, it can also come from the lipids, right? Hello? Hello?
Yes.
Yes.
So let's say that T3 and T4 would increase the breakdown of your lipids, increase the breakdown of your glucose in order to give us a lot of ATP because its function is to increase the activity of NAK+. So can I say that the function of T3 and T3 basically is breakdown of lipids. Can I say that? Increase blood sugar level. Okay, increase basal metabolic rate. Can I say that? And increase your beta adrenergic effect on your B1 receptor on your heart. So if we have increased activation of B1 receptor, we are going to be having more cardiac output, more heart rate, stroke volume would increase. But we know beta 1 is also present in the JG cell, right? Increase renin, increase aldosterone, increase effective circulatory volume, hypertension, right? Am I right?
Yes.
So these are going to be the functions of your thyroid hormone. But a really important function in the primitive ages, thyroid also helps your brain maturation. Brain maturation. You are going to be having a lot of MCQ on that as well. Like initially, right? What happens? You need thyroid hormone in order to have proper maturation of the brain. So that's why in the US, like most of the babies are basically tested with their thyroid function, because at that appropriate developmental age, if you do not provide thyroid hormone in that specific period, it can end in temporary like mental retardation, right? After that, if after that period of time, if you're just giving the thyroid hormone, it won't help. So it means it's a really concerning, thing. You should just keep that in mind, right? So brain maturation is very important. Along with that, it also increases your bone growth, right? Bone growth, really important. Okay, so these are all of the functions of your thyroid hormone. And T3 itself again have a negative feedback inhibition on your TSH and TRH. Keep that in mind, right? And T3 is like, important in negatively inhibiting your TSH or TRH. That's really important. Is that clear? Hello?
Yes.
Okay, perfect. So the thyroid basically, once released into the blood, it basically bind with tyrosine binding globulin. So we are having a big globulins which are going to bind your T4, and it's going to carry it, or like it's going to take it into its required location, right? So sometimes what happens that the thyroxine binding globulin can increase, and as they increase, it won't let the T4 to separate from T3, from the globulin, right? So if you have this condition, like for example, with the use of oral contraceptive pills, that is increased estrogen can increase your thyroxine binding globulin. And as a result of that, although the total T3 and T4 concentration increases, but the free T3 concentration will decrease. Keep that in mind, right? Hello. Similarly, if you have a nephrotic syndrome, you know they are globulins, right? They are protein. And what do we see in nephrotic syndrome? We have loss of proteins in urine, right? So sometimes the thyroxine binding globulin can decrease, and as a result of that, the total T3 and T4 can decrease as well, right? Keep that in mind, really important. So the next hormone which we are going to be discussing, okay, I'm just spending a lot of time on this physiology, so I'm expecting you guys to be, you know, active in pathology. You guys are going to be, you know, contributing more on that, okay?
Excuse me, sir.
Yes, please.
Sir, like you said that in the nephrotic syndrome, the thyroid binding globulin would like decrease.
Yes.
So the T3, T4 should increase then, right?
The total T3, okay. So how do we count total T3 and T4 whenever we have like, you know, okay. Okay, so basically, you know, the decrease in steroid, okay. So if in nephrotic syndrome, if you're losing the binding globulins, right? So the
Yes.
total T3 and T4 decreases basically.
Yes, but the free ones, they would.
Yes, the free one, yes, obviously the free one is going to be increased, right? But the
Yes.
total decreases, right? Because the total means both T3 and T4, right? So the total
Yes.
decrease while the free can increase, yes.
Yes. Yes. Thank you.
So
sir.
let's discuss our next topic, that is parathyroid hormone, right? PTH. Okay. So parathyroid hormone basically comes from a parathyroid gland, right? Parathyroid gland. Okay. And as we know that parathyroid gland is present at the posterior aspect of your thyroid gland. And what's the function of parathyroid hormone? It's going to increase your calcium within the serum or your blood. Okay. Along with that, it's also okay. It's PTH, phosphate tracing hormone. It's going to decrease the reabsorption of phosphate in your proximal convoluted tubule. Keep that in mind, right? Okay. So how do it increase your calcium level? That's very important, right? Okay, just give me a second. Just give me 1 second, okay? Okay, so we were discussing about parathyroid hormone. It would increase the calcium level, right? So how do it increase the calcium level? We know the major reservoir for the calcium are your bones, right? So it's going to act on the bone. And can you just please fix your mic? Please, Dr. Margaret, please. Okay. So the major reservoir for your calcium is bones, right? So it's going to act on your bones. It's going to increase the osteoclastic activity, and as a result of that, it's going to release your calcium into the blood. So let me just mention that, right? So we have osteoblast and we have osteoclast. Osteoblast help in formation of bones, while osteoclast help in destruction of your bones, right? Breaking down your bones. So it would increase the activity of your osteoclast, and as a result of that, calcium is going to be released into the blood. So this is the mechanism in which, through which your parathyroid hormone basically increases your calcium levels, right? Besides that, remember, we have an enzyme which is known as 1-alpha hydroxylase, right? And 1-alpha hydroxylase is basically present within the proximal convoluted tubule, right? So for the normal calcium reabsorption, there is another pathway as well. For example, as the sunlight falls on your body, the cholesterol components are going to be entering into your liver. It's going to be converted into 25-OH, calcitriol, right, or calciferol, right? Then this 25-OH, whatever, right, calciferol, right? It would just come to your proximal convoluted tubule, and here this enzyme is going to further add an OH on the first carbon, right? So it would just become 1,25-OH, right? 2D3 calcitriol, right? And it's basically an activated form of vitamin D, right? Activated form of vitamin D. Are you guys getting me? Normally, sunlight is going to fall on your skin. The cholesterol component is going to help in the formation of 25-OH calcidiol or calcitriol, right? Then what happens? It's going to enter into the proximal convoluted tubule. There, it's going to be further hydroxylated. Further, an OH is going to be added onto the first carbon by an enzyme 1-alpha hydroxylase present in the proximal convoluted tubule. And in this way, in the end, we are going to be having an activated form of vitamin D, which is called as 125 hydroxycalcitriol, right? And what this activated vitamin D is going to do, it's going to go into your gut, and it's going to lead to reabsorption of your both calcium plus phosphate, right? So, okay. So PTH also helps in this pathway as well. And how do it help in this pathway? PTH basically increases the activity of 1-alpha hydroxylase in proximal convoluted. If we have a lot of PTH, it would help the activity of this enzyme 1-alpha hydroxylase present in your proximal convoluted tubule. In this way, we are helping a lot of activated vitamin D formation. And again, once we have activated vitamin D, we are going to be having a lot of reabsorption of your calcium from your GIT or gut. And in this way, it's going to restore the calcium level within the serum of the blood, which is a primary function of PTH, right? So PTH basically helps in two ways, right? First, okay, not 2 ways, 3 ways, right? The third way we are going to be discussing. So the first way we discussed, it's going to be directly acting on the bone. It's going to be increasing the osteoclastic activity. As a result of that, calcium is going to be released into the serum or blood. Secondly, it's going to be increasing the activity of your 1-alpha hydroxylase in your proximal convoluted tubule. And in that way, it's going to increase the activated form of vitamin D, which is going to reabsorb a lot of calcium from your gut. The third way, what's the third way? The third way, PTH directly act on your distal convoluted tubule, and it can cause the reabsorption of calcium there, right? So in 3 ways, your PTH is going to help you restore the levels of your calcium. Is that clear?
Yes, sir.
And it's a phosphate trashing hormone. It would decrease the phosphate level in the blood. That's all about parathyroid hormone. You should know, okay? So the next topic which we'll be discussing is calcium homeostasis, right? So calcium basically bind with it's basically present in 3 forms. The free form, most abundant, 45%, bind to albumin and bind to certain anions, right? So whenever we have a lot of H plus, that is acidity, right? In that case, what happens? The H plus is going to compete with the calcium to the albumin, and in that case, we are going to be having more calcium released from the albumin, right? Hypercalcemia, right? Is that clear? And once we have decreased calcium, so more calcium is going to be binding towards your albumin. Okay, so let me just ask you a question, very important, very high yield. We have a lot of MCQs on that. We have an individual, we have hypoparathyroidism. What would be the level of calcium in that individual, high or low? In case of hypoparathyroidism.
High.
Hypoparathyroidism, high calcium?
Low calcium.
Low.
Low calcium.
It should be low.
Okay. We're going to be less parathyroid hormone, hypoparathyroidism. So it means you'll be having less calcium in the serum, right?
Less
All
calcium and increased phosphate, yeah.
Yes, an
Yes.
increased phosphate.
Phosphate will be increased because less absorption from the bone, from the kidney,
Perfect.
from GIT.
So if you have hypocalcemia, it would appear as 2 signs, 2 clinical signs. Just name those.
Chalk sticks and
Show stick.
And
Carpopedal spasm.
spasms.
Okay.
Shostak.
Okay. Shostak and
Carpopedal spasm.
Carpopedal spasms.
spasms. Like short, you can say there would be a lot of spasms, right? Because normally we know that the calcium is inhibitor of your sodium channels normally, right? So if you have hypocalcemia, you have no one to inhibit your calcium or your Na channels, and in that case, you'll be having a lot of flow of Na, which is going to sodium, which is going to lead to a lot of depolarization, and it would appear in the form of spasms. Is that clear?
Yes.
Okay, Shostak and translucent tapping of your facial nerve. You're going to be having spasms of the muscles, and inflating a BP cuff. You'll be having spasm of the muscles again, right? Due to increased depolarization. That's simple. Is that clear?
Yes.
Okay. Perfect. So, okay. So the next two hormones which we'll be discussing is calcitonin and glucagon. That's very simple. Then we'll be having a break of 10 minutes. Then we're left with 2 other hormones, and then we comes with pathology, which you guys are going to be helping us with. Okay. So the next 2 hormones are really simple. We have calcitonin, we have glucagon, right? Calcitonin. Calcitonin is basically opposite to your parathyroid hormone, right? So it's opposite to parathyroid hormone, released from parafollicular cells. As the parathyroid increases the calcium level in the blood, what your calcitonin is going to do, it's going to decrease the calcium level in the blood. That is, it's going to take the calcium, it's going to deposit it onto your bones, right? Calcitonin. What's the effect of glucagon? It's opposite to insulin, right? We'll be discussing insulin in detail, like insulin is an anabolic hormone. It's going to increase, okay. So after the insulin discussion, we'll be doing glucagon, right? Then it's going to be very simple for us. Okay, is that clear? So let's have 10 minutes of break and then we'll be continuing our session. Okay? Yeah, thank you so much.
Hello?
Hello? Hello, can you guys hear me?
Yes.
Okay, perfect.
Yes.
So let's continue our discussion. And the next hormone, which is really important, really high yield, you have a lot of MCQs on that, is insulin, right? Insulin, very important. Okay, so while we'll be discussing insulin, there are a lot of receptors which you guys should know what are the function of those receptors, how the insulin is made, and where insulin is made, right? So we already know that insulin basically is found within the beta cells of islets, right? We already know that. So how do the insulin normally forms? So remember, the insulin basically it's a peptide hormone, right? Insulin is a peptide hormone. So all of the peptides are basically formed by your ribosomes because ribosomes helps information of your peptides or proteins. And ribosomes we know are present on the endoplasmic reticulum that are known as rough endoplasmic reticulum. It means that insulin peptide hormone is going to be formed by your rough endoplasmic reticulum, right? So for example, if this is your rough endoplasmic reticulum having a lot of ribosomes, it's rough, it's called rough because the presence of ribosomes, right? So what happens, first of all, your DNA is going to be converted into messenger RNA, the specific genes encoded for the synthesis of your insulin. This messenger RNA is going to come, it's going to translate here, it's going to lead to the formation of your insulin, right? But first of all, it's going to be released in the form of pre-proinsulin, right? So pre-proinsulin basically is having a signal peptide from the pre-proinsulin. Once the signal peptide is cleaved off, it's going to be converted into proinsulin. And proinsulin is further going to be converted into C-peptide plus insulin in an equimolar ratio. What do we mean by equimolar ratio? That whatever concentration of C-peptide is released, same concentration of insulin is also going to be released. Okay, so the C-peptide is very significant because it's going to tell you the source of insulin, right? So there are going to be a lot of MCQs. Let me just mention one of the MCQs. We have an individual, he is having a lot of insulin. So how in a lot of insulin is going to appear? It's going to appear as, yes, it's going to be appearing as hypoglycemia because what's the function? Main function of insulin? It's going to push all of the glucose into your cells. If you are pushing all of the glucose into the cells in the blood, we'll be having hypoglycemia, right? Okay. So the next thing which you are going to be asked is the insulin, which is this hypoglycemia due to increased insulin due to any internal source, or is this insulin due to external source? That is either this individual is taking from an external source or internal. So for that, you have to look towards C-peptide, right? So for example, if insulin is coming from the internal source, what do I mean by internal source? For example, if we have a tumor, insulinoma, releasing a lot of insulin. So with that, the C-peptide is also going to be elevated, right? Because we know normally along with insulin, C-peptide also go up, right? So in case of insulinoma, we're having hypoglycemia, a lot of insulin, but along with that, we are also going to be having a lot of C-peptide as well. Is that clear?
Yes.
Hello? Perfect. But
Yes.
the insulin which is causing this problem, if increased insulin is due to some source, which is like, for example, if person is taking it from outside, right? A lot of people take insulin from outside, right? And that is causing this hypoglycemia. So the C-peptide levels are going to be less because in the synthetic insulin, we only inject insulin. We do not inject C-peptide. Is that clear? So this is the significance of C-peptide. Keep that in mind. We're going to be tested on this, okay? Okay. Is that clear? Perfect. So you should simply think that what's the function of insulin? As I already mentioned, it's going to take glucose into your cells. Right? So for example, if these are your cells, so what insulin is going to do, for example, if these are your adipocytes, right? So it's going to, act on a tyrosine receptor pathway, and in the end product is going to be installation of GLUT4 receptor. So once the insulin install GLUT4 receptor on your adipocyte, on your skeletal muscles, tissues, so what would happen? Now the glucose is going to enter into the cells, right? Can you just please fix your mics, Dr. Umi, UME? Please just fix your mic. Just turn off your mic, okay? So Once the glucose enter into your cell by the effect of insulin, which is like, increase or installation of that glucose receptor. So what's the fate of these glucose? Simply you can think of this glucose can be converted into different things. It can be converted into fats. It can be converted into proteins in case of your muscles. It can be converted into a lot of things, right? Is that clear? So can I say that it's an anabolic anabolic hormone that is going to like make a lot of things? Like in case of lipids, it's going to increase lipogenesis, right? Hello? Is that clear?
Yes.
Yes,
Perfect.
clear.
It's going to increase, okay, it's going to increase the triglyceride synthesis, fat synthesis, right? Okay, it's going to increase the protein synthesis. So if it's synthesizing a lot of things, it means that it's going to be, anabolic in nature. And the other effect of insulin is that, okay, insulin would decrease glucose level, while on the other hand, what's the function of glucagon? Glucagon increase your glucose level, right? So normally you have a proper balance of glucose. If the glucose level drop down, your glucagon is going to come into play. But normally with the release of insulin, insulin inhibits your glucagon. That's really important. We're going to be having an MCQ on that, okay? So insulin normally inhibits your glucagon. You'll be having an MCQ on that. Keep that in mind, okay? So, okay, another thing, insulin also increases the activity of your NAK plus pump. The activity of NAK plus pump was also increased by your T3 and T4, if you remember, right? Insulin also does that. So if it's increasing the activity of NAK plus, so can we use insulin in hyperkalemic state in order to correct hyperkalemia?
Yes.
Yes, of course.
Okay, perfect. So it's going to help correct your hyperkalemia. So it's one of the treatment of hyperkalemia that we are going to be giving, like glucose along with insulin in order to correct hyperkalemia. Very highly have a UL and on that as well. Okay, so this was all about insulin, right? Insulin, there are certain receptors that are insulin independent, like for example, the GLUT1 receptor, 2 receptor, 3 and 5. So in order to take glucose into the cells, these receptors do not require any insulin. Like glucose is open to flow through these receptors. Like GLUT1 are formed in your red blood cells, in your brain, cornea, placenta, right? So you have to memorize it from the first set. That's your task, okay? Okay. So as we discuss the entire synthesis, so how the insulin is released, that's also really important, right? For example, if it's a beta cells of your islet, right? So what happens normally that glucose is going to be entering into your beta cells. As the glucose enters your beta cells, it's going to undergo glycolysis, right? And in the end of glycolysis, we need that we're going to be having formation of ATP, right? Hello?
Yes.
Okay, and once we have ATP formation, so we have the specific cells which are known as K plus cells, right? Potassium. So this ATP further is going to close these K plus channels. So as the K plus channels or the potassium channels are closed, K plus or potassium is going to be keeping on accumulating within the cell. And as the potassium or the positive ions accumulate within the cells, what happens? It's going to lead to depolarization. We know whenever positive charges enter into a cell, it leads to depolarization, right? And upon that depolarization, it would also trigger your calcium channel to open. So on the depolarization, calcium are also going to enter into your cell. And these calcium are further going to help the release of insulin and C-peptide. So insulin and C-peptide are basically, they are in the form of a secretory vesicles. Whenever the calcium comes, it's going to, lead to the release of your insulin plus your C-peptide. That's really important, right? So in the pharmacology, we'll be discussing again this concept, so you should just keep that in mind, okay? So what happens? Glucose is going to enter into your beta cells. It's going to undergo glycolysis. Glycolysis is going to yield ATP. ATP further is going to block your potassium channel. As the potassium channels are blocked, as the efflux of your potassium are blocked, potassium is going to keep on accumulating in the cell. It's going to lead to depolarization. And if we have depolarization trigger, the opening of your calcium channels, calcium are going to go into the cell. It's going to help those secretory vesicles dump off their content that are your insulin and C-peptide. Is that clear? Hello?
Yes.
Yes.
Perfect. So there is another high yield concept, another high yield MCQ of your word, which you guys should know. We have two individuals. One individual just took glucose orally. Another individual just took glucose, via an IV injection, for example. In which set of individual there would be more release of insulin?
Oral. Oral.
Oral.
Why?
Because of the
Because
GLP-1 and all of
perfect, because of
Incretin.
GLP-1 incretin. So in the basically in your GIT and the duodenum, basically you have some certain substances which are known as incretins, right? So whenever the glucose comes there, it's going to increase the GLP, right? Orally. As the GLP are increased, so GLP have same mechanism, right? It would just close off your K plus channel and it would further help in the release of insulin. So oral intake of glucose is going to release more insulin in contrast with those individuals who are taking IV glucose. You have an MCQ on that, okay? So the next page is adrenal steroid, adrenal hyperplasia. We will be discussing that in our pathology section. For now, we are going to skip that, and we'll be discussing our last hormone in physiology, that is cortisol, right? Really important, really high yield. As I mentioned, I'm spending a lot of time on physiology because I'm expecting you guys to be participating in the pathology section. I won't be writing anything, okay? That would be a pure discussion session because entire physiology of hormones, it's a pathology. What is pathology? Opposite of physiology. If you know physiology, just you're going to speak some words opposite to what we learned already, okay? Perfect. So let's discuss what is cortisol. Okay. So as we know first of all, how the cortisol is released, right? So we know we have our hypothalamus. Again, we have our pituitary stalk, anterior pituitary and posterior pituitary. CRH is going to come, the releasing hormone, acting on cells which are going to make ACTH. ACTH are further going to come down. It's going to act on zona fasciculata and reticularis. On the zona fasciculata, it's going to release cortisol. Is that clear? And cortisol further is having a negative inhibitory action on your ACTH. Is that clear?
Yes.
Okay. Just give me a second. Okay. So it's a normal pathway for your cortisol. Now let's discuss what are the function of your cortisol. So in order to remember the function of cortisol, keep one thing in your mind, right? Or two things in your mind. Cortisol is a stress hormone. Right? So for example, whenever we are in a stressful situation, for example, if you are running, right? So a sympathetic like the drive is going to be activated, right? In a stressful situation. And for this stressful situation, you need a lot of energy. For example, if I'm running, right? I need a lot of energy. So in that stressful situation, your cortisol is going to be released. And for the energy, we need glucose. It means that cortisol is going to increase your glucose within your blood. From how do we increase glucose? From where do the glucose come? Glucose can come from your carbohydrates. Glucose can come from your lipids. Glucose can come from your proteins, right? So it means if you have a lot of cortisols, it's going to increase the lipolysis. It's going to, it's going to increase gluconeogenesis, right? It's going to increase gluconeogenesis. That is conversion of a non-carbohydrate source into carbohydrate source. That is conversion of proteins into your, basically your glucose. Okay, so you have to keep this thing in mind. Okay, and another thing, it would increase the blood pressure. How do it increase blood pressure? It do not directly increase the blood pressure. That's really important. It helps in the increase of blood pressure. That is, it's having a permissive action. You have a U-word MCQ on this, permissive action of cortisol in your CNS body, right? So it's very important, right? You should know. What do we mean by permissive action? Okay, I just told you it's going to help increase your blood pressure, right? So normally, how does the blood pressure increase? We know whenever we have sympathetic drive, norepinephrine, epinephrine are going to come. It's going to act on alpha-1 receptors. This is going to cause vasoconstriction, and in that way, it's going to increase your blood pressure, right? Hello? Okay, so how the cortisol is going to help. Cortisol is going to increase alpha-1 receptors on your entire vasculature, right? So it's not directly causing the increase of blood pressure, but it's helping increase your blood pressure via installing a lot of alpha-1 receptors on your vasculature, right? But other thing it would decrease the fibroblast activity. So the fibroblast activity is decreased, you won't be having proper formation of collagen. If you do not have collagen formation, so in hypercortisolism, it would appear as an abdominal stria. We'll be discussing that, okay? And another thing, you know that cortisol are glucocorticoids, and glucocorticoids basically inhibits your, yes, your inflammatory, your immune cells, your immune response, right? For example, if you have an individual with asthma, right, we're going to give him glucocorticoids. We're going to give glucocorticoids in a lot of conditions where we want the immune cells to be, down. For example, in SLE, right? Systemic lupus erythematosus, which is due to exaggerated, it's basically type 2, type 3 hypersensitivity. That is an exaggerated response of your immune system. So in order to correct that pathology, we are going to give glucocorticoids. Why? Because glucocorticoids inhibits your immune cells, immune system, immunity, right? Keep that in mind. Okay? Is that clear? Hello?
Yes.
Yes, sir.
Perfect, right? So that was all about cortisol. Okay, what does the cortisol do to bone? It decreases the bone formation. Keep that in mind. Decrease your osteoblast activity or increase your osteoclast activity, right? So it was all about physiology, the important concept. So then we have a signaling pathways. We have some appetite regulation hormones. That's your homework. Signaling pathways. It's entirely memory. Just memorize it. It's going to be your homework. So let's start pathology, right? So we are going to be discussing pathology from pathoma, right? So kindly just open your pathoma book, and we are going to, discuss pathology from pathoma. Okay. So I'm giving you 2 minutes. Those who do not have their books, just put your books and open your books, okay, in front of you.
How do we have the pathoma book, doctor?
Okay, so it's simple, right? You can just, take your phone and you can just search it on Google, pathoma PDF, right? You can just open that, those who do not have, right?
Okay.
Yeah, perfect. So it's basically your page number. It's
159.
459?
159. 159.
159, yes, it's 159. Okay, so as I already told you, I won't be, I'll only be helping you with pathology. I'll be just marking the higher concepts here, right? And you guys have to tell me a lot of things, right? So everyone should be ready. I'll be asking you guys. You guys have to turn on your mic, and in this way, we are going to be discussing. Okay, I was just seeing some conversation in the group. So a lot of students are discussing that we should be having, a lot of catch-up days and things like that. Okay, let me mention that we are going to stay strict to our schedule, right, which we have already made. And, in this way, then we will be able to complete the entire course within 120 days. Since you guys know that everything is going quite perfect, you guys are scoring too good. So just, we are already done with 2 systems. So, just stay on the track. Whatever we are just, posting in the groups, just follow that, okay? Okay. So we'll be starting from pituitary adenoma, right? Okay. So who's going to be telling me? Okay, let me, Dr. Bermet, Bermet. Can you just please turn on your mic? Hello? Okay. Dr. Humera. Dr. Humera, can you just please turn on your mic? Let's have some discussion on a couple of topics. Dr. Humera. Hello? Dr. Amita, can you please turn on your mic? Hello? No response, right? Hello? I think no one want to participate. Okay, Dr. Abdul, can you please tell
Yes,
me?
sir.
Okay, thank you so much. Perfect. So the first, okay, all of you guys must be having their pathoma in front of them. So the first topic which we're going to be discussing is pituitary adenoma, right? So we'll be having some discussion over pituitary adenoma. So Dr. Abdul, can you just tell me what is adenoma?
Adenoma is a benign tumor.
It's a benign tumor. So this tumor can be of two types, a functional or a non-functional. So what do you mean by a functional adenoma?
So functional adenoma that is causing the secretion or inhibition of certain hormones or secretion.
Perfect. So if we have a tumor and it's actively releasing hormones, that's going to be a functional adenoma, right? Or a functional benign tumor. And if it's non-functional, it won't be releasing any hormone. But the problem with the non-functional is that this non-functional tumor can just compress certain structures of your anterior pituitary. And long-term compression of those structures can lead to degeneration of your anterior pituitary, which can lead to hypopituitarism. Is that right? That's known as mass effect, right? So this big mass can just cause compression. Compression can lead to degeneration of your anterior pituitary, which is going to give you hypopituitarism, right? And okay, perfect. Then we have prolactinoma. So we already know prolactinoma, and I think we have to skip this topic, right? We already discussed each and everything about the prolactin. So yes, Dr. Abdurrauf is going to give us a quick overview. Prolactinoma, yes.
So, sir, when the prolactin, like there is a enlargement of prolactin in the body, so it is causing a lot of secretion of the prolactin in our body. So that would decrease the GnRH secretion, the gonadotropin releasing hormone. So that's why the secretion of the FSH and LH would also decrease, and that would simply lead to like the amenorrhea in the females, along with infertility and decreased libido. And the same would happen in the males, like decrease in fertility and libido.
Perfect. Okay, perfect. Okay, what's the effect of dopamine on your prolactin?
Dopamine basically inhibits the prolactin secretion. So when the dopamine levels are high, so prolactin would be low, and the prolactin also itself increases the dopamine secretions for a negative control, like an inhibitory control over itself. And the thyroid releasing hormone, the TRH, basically increases the prolactin secretion. But the dopamine has a greater effect on the regulation of prolactin as compared to the TRH.
Perfect. That's perfect. So let me just throw a scenario, okay? So Dr. Abdurrauf is going to just tell me that, okay? We have an individual, he's having a schizophrenia, right? What is schizophrenia? You know, it's in psychiatry, we'll be discussing that in detail. Basically, what's the main goal of schizophrenia? We are going to be having a lot of dopamine and a lot of pathways, right? So there are tubulo, cortical pathway, there are a lot of pathways. So what happens? The dopamine level increases, and for that we are going to give them like antipsychotics, right? And what's the main goal of antipsychotics? Like for example, haloperidol is going to inhibit your dopamine, right?
Yes.
Sometimes it can inhibit the dopamine everywhere.
Yes.
If it's inhibiting dopamine, can we have prolactinoma as a result of an individual having schizophrenia with antipsychotics?
Like we will have the increased secretion of this prolactin. So that's why those people like on such antipsychotics or such drugs, they can also have infertility because of that.
Perfect. If the dopamine level decreases in the nigrostriatal pathway, since Dr. Abdurrauf is our old student, old is gold. So I'll be just asking some other aspects of this MCQ as well, right? So Dr. Abdurrauf, can you just tell me if the dopamine decreases in the nigrostriatal pathway, which pathology are you expecting in this individual?
So when the dopamine pathway will be affected because of we are taking the antipsychotics or any such drug, so the prolactin secretion would increase in this patient, and that increased secretion of the prolactin would again lead to the same effects, that the GnRH would be low and the FSH-LH would be low, so the patient will be having infertility or decreased libido.
Okay. I'm asking if the dopamine decreases in the nigrostriatal pathway. Did you remember the nigrostriatal pathway, substantia nigra?
Yes, sir.
It will be same as Parkinsonism, right?
Yes, sir. Yes, sir.
Perfect. That's perfect, right? Okay, perfect. So the next topic is gigantism acromegaly. We already discussed that, right? So Dr. Abdurrauf again is going to be telling me what is gigantism, what is acromegaly. You know the physiology. Just flip the physiology, and that's your pathology. Yes.
Yes. So, sir, basically in the acromegaly or gigantism, basically the growth hormone secretion is more in our body. It's an uncontrolled secretion of growth hormone. So when it occurs in the juniors, like the children, so we will have gigantism because in them till now the epiphyseal plate closure has not occurred. So
Perfect.
they will have a proportionate growth of all their extremities, like limbs and everything. But if it occurs in the adults whose epiphyseal plate has already closed, so this would result in a disproportionate features of increased growth hormone, like they will have coarsening feature of their face, they will have like widening of their maybe their foot and their hands, and they can also have hypertrophy towards their heart, and these kind of symptoms will be seen.
Perfect. Enlarged tongue. Perfect. That's perfect. Okay. So, for example, if you have an individual you are suspecting an acromegaly, if you are giving him glucose, would the glucose inhibit your? Okay, would this individual be having any diabetes?
This individual
With acromegaly.
acromegaly, I'm not sure
Yes,
about
can.
the habit.
Yes.
You're
Yes.
Yes,
okay.
yes, because there is
Yes.
increase of
Dr.
glucose level.
Abdurraouf, we discussed that growth hormone increase your glucose level. So it's a diabetogenic. We already discussed that, remember?
Yes, sir. Yes.
Perfect. What would be the treatment? Give them somatostatin or octreotide, right?
Yes. Somatostatin or the surgical resection of that.
Perfect. Perfect, right? Then we have ACTH. If you have a lot of ACTH, it's going to trigger a lot of cortisol, which is going to appear as Cushing syndrome, Cushing disease, right?
Yes.
Okay, we are going to be discussing that in our further lectures, right? Then we have hypopituitarism. What is hypopituitarism or pituitarism? Whenever we have low hormones, right? For example, the craniopharyngeal. Okay, what is Sheehan syndrome? Who's going to be telling me the Sheehan syndrome?
Yes, sir.
Infarct of the pituitary after a postpartum like birth, like after the child is born and there was some kind of.
Okay, so what would be the classical presentation of an, or what would be the classical complaints of a lady with Sheehan syndrome?
Amenorrhea.
Food
Amenorrhea
lactate, loss of
Failure
liquor,
to lactate.
will be
Please,
amenorrhea.
one by one,
Failure
one
to
by one, one by
lactate.
one, one by one. Please raise your hands. Please, 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 please. Okay. Okay, Dr. Jamil. Yes.
Yes, sir. During pregnancy, if we start from the pathophysiology,
Yes.
increase the size, increase the function of the pituitary gland, and increase the size of the pituitary gland.
Perfect.
And yes, increase the blood supply of the pituitary gland. And when there is severe hypotension, in case of severe bleeding during SVD, normal delivery, or CS, there is a severe hypotension. It will compromise the blood circulation of the pituitary gland. This will cause the Sheehan syndrome, and then secretory function of the pituitary gland decreases. After occurring this means the event, postpartum, the female complaint of tiredness, lethargy, low blood pressure, and decrease all the hormones from the anterior pituitary.
Okay, perfect. So first of all, the lady would complain that she cannot lactate, right?
Yes.
Yes,
Yes, this
because
is the first sign.
Poor lactation.
Yes.
Loss of pubic hairs. Loss of pubic hairs.
Fatigue.
Okay, because the GnRH also decrease, ACTH also decrease. Okay, so loss of pubic hair. These two are going to be the classical complaint. Okay, so as Dr. Jamil told us, in Sheehan syndrome, normally in pregnancy, the activity of your pituitary increases, so the size of pituitary also increases. If after we have a postpartum, bleed, a lot of bleed, so what would happen now? This increased size pituitary is going to be vulnerable toward ischemia. It would become ischemic and it would die off. Once the pituitary die off, it won't be secreting hormones. Is that clear? Okay. So then we have a pathology which is known as empty sella syndrome. What is sella? Normally your pituitary lies in a bony structure or a bony pocket, right? That's known as sella turcica. Remember
Sella
that, right?
turcica, yes.
So what happens in empty sella syndrome, that congenitally we do not have anything in sella. What is normally present in the sella? We have pituitary. So if we do not have pituitary in the sella, we would be having hypopituitarism, or also known as empty sella syndrome. And in other way, it can appear in a form that, for example, we know that the sella is also, covered by your meninges, right? So sometimes what happens, the CSF leaks into the sella, and the CSF leads to chronic, compression of your pituitary, and chronic compression can again lead to degeneration of your pituitary, resulting in empty sella syndrome. If you have empty sella, no sella, it means you are going to be hyperpituitarism. Is that clear? So regarding the ADH, we already know the function of ADH. Now we'll be discussing the pathologies related to ADH. That is central diabetes insipidus, nephrogenic diabetes insipidus. So what is diabetes? Why do we call it diabetes insipidus? Because in diabetes, we know we are going to be having a lot of urine formation, right? A lot of urine formation. So both in central diabetes insipidus and nephrogenic diabetes insipidus, we are going to be losing a lot of water within the urine, right? And what do we call whenever a lot of urine is lost in the urine? What's the term used for that?
Polyuria.
Polyuria, perfect. And why would we be having a lot of water in the urine? Because the ADH won't be functioning. Either the ADH won't be present, or either there would be ADH, but the ADH won't be functioning, right? So what's the function of ADH? Reabsorption of water. If you do not have ADH function, it means we are going to lose a lot of water in the urine. If you are losing a lot of water in the urine, the patient is going to be hyperosmolar, right? The osmolar concentrations are going to increase a lot. So what is central diabetes insipidus? If an individual is having decreased ADH, that is, for example, due to trauma, if an individual is having a life-threatening trauma, and let's suppose it leads to destruction of your posterior, or not posterior pituitary. Remember, right? Why do we have diabetes insipidus? And first, if we have trauma to the nuclei in the hypothalamus, which are making your ADH,
Median eminence.
it's basically damage to the nuclei, right? Hypothalamus damage. So we will be having less ADH. If we are having less ADH, this individual will be having polyuria. Hypernatremia. Why? Because we are losing a lot of water. The osmoles are going to become concentrated. Sodium is going to become concentrated. It's going to appear in the form of hypernatremia. Is that clear? For that, we have to do water deprivation test in order to. We have another condition as well. That is psychogenic polydipsia. We'll be discussing that in our in our psychiatry. Okay. So what happens? We are going to do. Yes, please.
Yes, doctor, because they said if sodium follows water, why is it here now that water goes and sodium remains?
Okay. So
And
as
it's
we
causing
already
hypernatremia.
Okay, you're just asking why do we have hypernatremia, right?
Yeah.
Okay. So the answer for that is really simple, right? Can you guys just see my screen? Okay, what's the function of ADH? ADH reabsorb your water. Okay. So the osmolarity is basically 290. We already know that. And the main electrolyte which contribute to this osmolarity is your sodium. Okay. So if you do not have ADH in case of central diabetes insipidus, it means we are going to lose a lot of water. So for example, if we have a solution, it have a lot of NaCl and we have water. If I'm only removing the water content from this solution, so won't this solution become concentrated with sodium?
Yeah, with the solid, yes.
So we'll be having hypernatremia, right?
Yes.
Is that clear? Because you're concentrating the extracellular fluid volume by losing a lot of water, by not reabsorbing water due to absence of ADH. Is that clear? So the urine osmolarity is going to be low while the serum osmolarity is going to be high. And what's going to be the treatment? The treatment is simple. Give them ADH, give them desmopressin. Is that clear?
Yes, sir.
What is nephrogenic diabetes insipidus? If we have ADH, but the ADH isn't functioning. What do I mean that ADH isn't functioning? The ADH isn't absorbing water, right? That is, the kidneys are resistant to your ADH, right? So that's going to be your nephrogenic diabetes. And how do we develop that? Okay, nephrogenic. Okay, there are a lot of drugs. Lithium is basically used. It's a mood stabilizer, right? It's basically used in bipolar disease, right? So you guys know that, right? So lithium causes a lot of problem, not even nephrogenic diabetes insipidus. Like in the cardiology section, if you guys remember, what pathology is caused by lithium? Yes.
Epstein anomaly.
Yes, Epstein anomaly. That is arterialization of your heart. In the thyroid, what pathology is going to be caused by lithium? Really important.
Hypothyroidism.
Hypothyroidism.
Perfect. Right? Okay. And in the kidneys, it's going to cause nephrogenic diabetes insipidus. Demaclocycline can also do that. So, for example, first of all, if you have an individual with diabetes insipidus, now you have to differentiate whether it's a nephrogenic or whether it's a central. So, for that, we have to undergo a water deprivation test. Normally, if we deprive an individual of water, so the osmolarity would increase, it would release ADH, right? So, if you're restricting water and, you're going to know that, yes, there is some kind of problems present, right? So, the ADH is going to increase and normally it have to reabsorb water, right? But if the ADH do not increase, it means there is going to be some problems with ADH, right? If still is producing a lot of amount of your urine, so either it can be nephrogenic or it can be central, right? So if it's central, we have to look towards the level of ADH in the blood then, okay? If the ADH are high and still an individual is producing a lot amount of urine, then the diagnosis is nephrogenic diabetes insipidus. If the ADH is less, then what you are going to do? You're going to administer ADH. And with that, if the problem is resolved, you should think of central diabetes insipidus. Is that clear?
Yes.
Perfect. Okay. Then we have another syndrome, that is syndrome of inappropriate ADH. That is completely opposite to diabetes insipidus. That is, we are going to be having a lot of ADH. And from where do we have this extra supply of ADH? That's going to be related to a cancer, right? Small cell lung carcinoma. Small cell lung carcinoma is a lot of things, right? Your ADH, we'll be discussing that in our respiratory section. So if you have a lot of secretion of your ADH, what will happen as a result of that? You are going to have more retention of water, right? Retention of more water, more free water. Is that clear?
Yes, sir.
Okay, pulmonary infection. So if you have more retention of water, so it would lead to, yes, it would lead to hyponatremia. You are diluting the Na, right? Low serum osmolarity, right? And if you have hyponatremia, it's going to lead to neuronal swelling. Is that clear?
Yes, sir.
Because we have less osmol outside, but more osmoles within the neuronal cells. So the water is going to enter into the neurons, which is going to lead to neuronal swelling, which would appear in the form of mental status changes, seizures, and cerebral edema. So what is going to be the treatment for syndrome of inappropriate ADH? The treatment is going to be cause a nephrogenic diabetes insipidus. Are you guys getting it? If you have a lot of ADH. Now we have to cause a pathology that is nephrogenic. Give demaclocycline, which causes nephrogenic diabetes. So it would decrease the resistance of ADH in your distal convoluted tubule, and in this way you can correct this pathology. Is that clear?
Yes, sir.
Thyroglossal duct cyst, we already do that, right? Already did that. So the next one is hyperthyroidism. Yes, it's going to be really easy because we know what's the function of thyroid. Okay, so we'll be discussing till max edema and we'll be continuing our bootcamp session tomorrow then, okay? Is that clear? We're also left with some of the cardiology. So, on the next Sunday, you won't be having any off day. So we have to cover a lot of things, right? Okay. Okay, perfect. So let's discuss what is hyperthyroidism. If you have a lot of function of your T3 and T4, what would happen as a result of that? You guys know the physiology.
Yes.
Yes, who is going to be answering that?
Like in hyperthyroidism, we will have different set of feature and systems. There will be heat intolerance, moist skin, warm skin because of vasodilation.
Perfect.
The thyroid hormones are acting on the beta receptors and causing dilation of the blood vessels directly. And we'll also have this ophthalmopathy related to that, Graves' disease, exophthalmos, and pretibial edema because of those same phenomena that the T cells act, their cytokines are released and they induce a lot amount of gag cells which bring a lot of water, so they cause the edema. And
Okay, perfect.
increased reflexes.
Perfect. So let's just start from the physiology. As we know that it would increase the basal metabolic rate. If you are increasing the basal metabolic rate, it means we are consuming a lot of ATP, right? And if you are consuming, and it also increases the sympathetic drive. So we'll be having like tachycardia, increased heart rate, and everything, right? So if you are increasing the ATP consumption by increasing your NAK plus ATP is pump, So an individual is going to lose a lot of weight. He's going to be having increased appetite, heat tolerance, because burning of your ATP yield heat as well. Tachycardia, arrhythmia, right? Due to that increased activity of your heart, your sympathetic response, it can induce tachycardia. Tremors, anxiety, insomnia, heightened emotions, all associated with increased sympathetic activity. Okay, oligomenorrhea. But another thing, very important, really high yield, one of your world MCQ. What's the effect on? Okay, what's the effect on cholesterol?
It will be decrease.
And decrease the
Decrease.
cholesterol,
Why?
all lipids.
Because your T3 and T4 also increases your LDL receptor on your liver.
LDL receptor.
So in hyperthyroidism, if you increase the LDL receptor on the liver, so a lot of cholesterol is going to enter into the liver. So in the blood, we are going to remain with less cholesterol, hypocholesterolemia. While on the other hand, in hypothyroidism, we will be having hypercholesterolemia. Really important. Okay. Is that clear?
Yes.
Perfect. So we'll be having hyperglycemia, increased gluconeogenesis, glycogenolysis. Why? Because we need ATP. For the ATP, we need glucose. And in order to get glucose, we should be doing glycogenolysis and gluconeogenesis. Is that clear?
Yes.
Perfect. Okay. So the next topic is going to be our Graves' disease. So what happens in Graves' disease is we are going to be having an antibodies which are similar to TSH. The function is similar to TSH. So these antibodies are directly going to bind with TSH receptor on your thyroid. We already discussed, and it's going to increase the activity of your thyroid peroxidase. That is, it would increase the formation of T3 and T4, again giving you hyperthyroidism. But an important point to keep in mind, the TSH receptor are not only going to be present on your thyroid, they are also going to be present on the fibroblasts behind your eye. They are also going to be present on the fibroblasts in the shin area, right? So these antibodies are also going to bind towards those fibroblasts behind your eye, and the fibroblasts are going to become activated and it's going to push your eye outward, which is going to appear as exophthalmos. So whenever we have hyperthyroid symptoms with exophthalmos, go for Graves' disease. And in this case, if antibodies are directly binding to your receptor, it means that it's a type 2 hypersensitivity, right? So we'll be discussing hypersensitivity in our immunology section. Different types of hypersensitivity and everything. Is it clear?
Yes, sir.
Perfect. So we are going to be having hyperthyroidism, and all of the features are similar as we already discussed. Okay, and pretibial myxedema, because TSH receptors are present in there as well. So it would increase glucose aminoglycans accumulation, and it's going to lead to edema, right? Okay, if you have a lot of T3 and T4, what would happen to the level of TSH? One of your UL MCQ, high or low? Negative feedback
Low.
inhibition.
Low.
What will happen to cholesterol? One of your UL MCQ, high or low?
Decrease.
Decrease.
Low.
Perfect. What are going to be the treatment? Okay, if an individual appear in the clinic and he's having tremors, he's having insomnia, he's having heightened emotions, he's having exophthalmos, what's the first line of treatment which you guys are going to do? Yes.
Beta blocker.
Beta
Blockers.
Propranolol.
Propranolol, beta blockers. Perfect. Before starting an individual on thionamide therapy, that is, before starting on the PTU or methimazole, first of all, you should be giving him beta blocker. Why? Because the life-threatening consequence of hyperthyroidism is going to be heart problems, arrhythmia, right? So first of all, you're going to decrease the beta receptors, right, in order to avoid. And secondly, we also discussed that beta blockers also help in blockade of your 5' deiodinase. It would also decrease the level of your potent hormone T3, right?
And also beta blockers rapid onset, as compared to
Yes,
the
and rapid onset. Perfect. Right. So PTU and methimazole. PTU basically inhibits your thyroid peroxidase, right? Really important MCQ of your UWorld. We have a pregnant lady. In the first trimester, she's having hyperthyroidism. Let's suppose. Which drug are we going to give her?
PTU.
Methimazole or PTU?
Parathyroid.
Perfect. Why?
Because methimazole is teratogenic in the first.
Methimazole is
Teratogenic in the first trimester. Perfect. In the last trimester, we are going to give PTU or methimazole.
Methimazole.
Why not PTU?
Because of the hepatotoxicity.
Hepatotoxicity of PTU. Very important, very high yield. 2 of your UL MCQs covered, okay? So that was all about hyperthyroidism. Next one is hypothyroidism, and then we are going to, continue our discussion tomorrow, right after Dr. Mo's class. Is it clear? Okay,
Yes.
just give me a second because Dr. Moaz just told me have to also have to do something, some topics with you guys. Okay. Just give me 1 second. Let me just contact him if you want to do it now. Okay, so Dr. Moaz is going to discuss this tomorrow with you guys, right, after the class, and we'll also be continuing our bootcamp session, okay? So, okay. So, then we have hypothyroidism, right? So what happens in hypothyroidism, we already know that, right? Everything you can just reverse from the hyper, right? Opposite of hyper is going to be hyper. So what is opposite to hyper? Dr. Jamil, yes. What are going to be the symptoms?
In hypothyroidism, will be in intolerance to cold.
Okay.
Also, the patient weight gain, and also will be lethargy. But
Intolerance,
if
bradycardia,
bradycardia,
oligomenorrhea,
yes, dry
hypocholesterolemia or
skin,
hypercholesterolemia?
hypercholesterolemia.
Hyper, perfect. Again, one of your keyword MCQ, right? Okay, let me just discuss another MCQ with you. We have a baby born. Okay, at the time of your the birth, he do not have exposure of thyroid hormone to his brain, or he was having hypothyroid. It's going to result in what?
Cretinism.
Cretinism, right? That is poor brain development as well. So we'll be having short stature as well, because we discussed it helps in the bone formation as well. And along with that, there are some of the classical features going to be present in cretinism: umbilical hernia, really high yield, enlarged tongue, coarse facial features. Three things: umbilical hernia, coarse facial features, and enlarged tongues. Is that clear? So what happens? It's going to result in formation of myxedema. And what is myxedema? It's going to be a glycosaminoglycans accumulation. In the skin, it would appear in the form of pitting or non-pitting edema.
Non-pitting.
Non-pitting.
Non-pitting or pitting? It is having a dough-like consistency.
Pitting edema.
Oh, pitting edema.
Yes, what do you guys think? Just confirm that. Is it a pitting or
I
non-pitting?
think pitting in
edema.
liver and heart failure,
Non-pitting.
I think
and
it's
will be non-pitting
non-pitting. Yeah.
Non-pitting.
because
Okay.
yeah.
Okay, just confirm that. Okay.
Yes, sir. It's in
Yeah,
the first
exactly.
mixed
Pitting
edema.
is a heart failure. Non-pitting
Okay.
is an
Okay, it's going to be non-pitting edema. Okay.
Yes.
Okay. So that's all about today's lecture. And tomorrow we are going to be continuing with our further topics, that is thyroiditis. Thyroiditis is really important. I'm going to, make it really easy for you guys. I'm going to mark all of the UWorld MCQs with you as I already did. So in this bootcamp session, like, we are not only going to be covering the high yield, first aid, pathoma, but along with that, we also discuss some NBMEs MCQ along with that with you. So it's going to be a better platform for you to revise things as well, right? So please take care of taking these sessions consistently. Okay, so in 2 hours I'll be sharing the assessment. After the assessment, I'll be sharing the weekly schedule of your renal as well, right?
Yes, sir.
Okay, so I hope so you guys enjoyed the session. Thank you so much. Thank you. Have a nice day and see you tomorrow. Okay, thank you. Bye-bye.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank
Thank
you.
you.
Doc.